Well, welcome everyone to our webinar today, the who, what, where, and when of COVID-19 treatments, everything you need to know about life-saving antivirals. The CDC Foundation is so pleased to host this webinar in partnership with the Vaccine Equity Cooperative and Health Leads. This webinar is part of our ongoing commitment to support those of you working in communities and partnering with communities to fight this pandemic. I'm Dr. Lisa Waddell, the Chief Medical Officer for the CDC Foundation, and I will serve as today's moderator. Now, today's webinar is available in Spanish. To listen to this presentation in Spanish, click the globe interpretation icon at the bottom of your Zoom screen and select your language. This webinar also has closed captioning option. To enable the closed captioning, please click on the closed captioning icon on the bottom of the Zoom screen. Now, before we begin our conversation today, there are a few housekeeping items we'd like to review. Today's webinar will be recorded and sent to everyone who registered along with any materials shared. During today's webinar, we will have time to answer as many of your questions as possible. Please submit all of your questions using the Zoom Q&A button found on the bottom of your screen. You can also use the Zoom chat feature to share comments, reactions, and links with your fellow attendees and panelists. And then last but not least, at the end of the webinar, we will be launching a poll and evaluation survey. So please take time to quickly share your feedback on today's webinar and suggestions for future offerings. Now, during our conversation today, our goal is to share as much information and guidance as we can on COVID-19 antivirals and discuss how we can overcome the barriers communities are facing when trying to access this life-saving treatment. To make sure your communities have all of the information they need on this topic, we are thrilled to have a number of expert speakers with us today. You can see them here on the screen. We have Dr. John Brooks, Dr. Cameron Webb, Dr. Julia Skapik, and Dr. James Coleman. Dr. John Brooks will speak about the current CDC recommendations and frequently asked questions. Dr. Cameron Webb will talk about the test to treat initiatives, where to find antivirals, and more. Dr. Julia Skapik will share insights and recommendations from the National Association of Community Health Centers. And Dr. James Coleman will highlight how the G.A. Carmichael Family Health Center, located in Mississippi, is overcoming barriers in that state. We'll also have a poll to learn more about the barriers your community is experiencing and the resources you all need before ending with question and answers from the audience. So now let's get started with Dr. Brooks, who is the Senior Science Advisor with the CDC Emergency COVID-19 Response. He's the Chief Medical Officer. He's with the CDC's Division of HIV Prevention, and he'll kick us off with an overview of the current recommendations and resources on antiviral use, especially Paxlovid. Dr. Brooks.
Thank you, Dr. Waddell, and welcome everybody. I'm glad to see so many people are with us today. You can go ahead and go to the next slide since Dr. Waddell already introduced the title of the session. And what I want to go over with you today is some basics around the medications that are available for outpatient use to treat COVID-19. So these are the medications that we really want to make people aware of because they're the ones that are available to consumers, hopefully prior to any need to be in a hospital. Just a couple of things. That first of all, these medications, let me back up. This is an image from the NIH COVID-19 treatment guidelines that summarizes what the available medications are. And you'll notice that there are 4 in bold here, separated into 2 categories. Those that are preferred because they are, for a variety of reasons, have been shown to be, there's good science behind their use and they're widely available, and there's other reasons to want to put them in the preferred list. And there are 2 that are alternative. However, any of these 4 can be used and can be made available to a person who needs them. First thing about treating people who are outpatients is an outpatient who is eligible or appropriate for these therapies is someone who is not requiring hospitalization or supplemental oxygen. As well, these therapies are recommended under FDA's emergency use authorization for people who have a high risk of progressing to severe disease if they were if they have COVID. So the idea here is we're trying to use these medicines to prevent people who are at a particularly high risk of going on to have severe disease from developing that. These medicines all work, and let me go over with you what they are. Top of the list right now is the drug you know is Paxlovid. It's technically ritonavir boosted nirmatrelvir, and nirmatrelvir is a integrase inhibitor, and the ritonavir boosts its effect. Second is remdesivir. Each of these is top of the list. The next two are the drug bebtelovimab. This is a monoclonal antibody. It's the only remaining monoclonal antibody that's currently recommended for use in the outpatient setting. There were a whole bunch of other ones you've probably heard about if you remember, even I guess it started about a year and a half ago. But unfortunately, the virus has learned to develop resistance to these. And so now the one that remains that is still useful is bebtelovimab. And then lastly, molnupiravir. And I want to point out that although bebtelovimab is the remaining monoclonal antibody, the other three drugs are all what we call small molecule antivirals, or basically these are specific medications that you can take to prevent or to treat rather COVID-19 versus receiving bebtelovimab. One thing I want to point out at the very bottom here, please note that the panel and other experts all recommend against the use of steroids, in particular dexamethasone, for outpatient setting. A lot of people are being prescribed steroids, we've learned, and there's no evidence that they're helpful and they may be harmful. So in the outpatient setting, you don't need to worry about steroids, just these four medications. Next slide, please. Let's talk a little bit about these medications in detail. So the most common drug, Paxlovid, the one everybody hears about, again, nirmatrelvir boosted with ritonavir, does have a couple of things I want to make sure you know about it. First of all, you have to start it within 5 days of symptoms. That third column, time from illness onset, if you're looking at the first row, that's our Paxlovid. Got to start within 5 days of symptom onset. It's a duration of 5 days. You take 3 pills twice a day for 5 days. Some important caveats with this drug is first, for people who have poor kidney function, something called eGFR, or their glomerular filtration rate, a measure of kidney function, you have to adjust the dose if they have low kidney function. And if somebody has a GFR less than 30, this drug is contraindicated. Secondly, this drug has a lot of drug-drug interactions due to the ritonavir. It's 100 milligrams of ritonavir. I'll talk in a minute about how you can learn about those drug-drug interactions. It shouldn't I want to reassure you that there are easy ways to manage this. Lastly, people who have advanced liver disease, Child-Pugh class C liver disease, they also are contraindicated for this drug. Remdesivir is an intravenous medication given at 3 doses, 1 day apart, starting with a loading dose and then 2 other smaller doses. And you can start that within 7 days of developing symptoms. Infusion, the difficulty with this one is, unlike pills, this requires actually going to a place where you can get an infusion or having someone come to your home to do an intravenous infusion. It can take up to 2 hours, and you have to do it 3 days in a row. Bebtelovimab is very convenient. It's a duration, you take it for 1 day, it's a one-time infusion like remdesivir, and you can start in less than 7 days. It's administered very quickly, but this drug is one I'll talk a little bit more about why it's not at the top of the list of those that we recommend. Lastly is molnupiravir. This is an oral medication like Paxlovid, also must be started within 5 days of illness onset, taken for 5 days. It's 800 milligrams. I believe it comes as 2 tablets that you take twice a day. This is a drug that not only has less effectiveness than Paxlovid, but also has raised some safety concerns. But there are people for whom Paxlovid, remdesivir, or bebtelovimab may not be the right drug, and then for them, molnupiravir would be the option to consider. Next slide, please. So let's talk about drug-drug interactions. That's the first of 2 things I wanted to talk to you all about. You may hear a lot about this. We have created tools to make it much easier for frontline clinicians to quickly check to see if there's a worrisome drug-drug interaction. The chapter in the NIH guidelines on COVID-19 that deals with drug-drug interactions has a lot of tables and information. If you're the kind of learner who does well by opening a book and seeing it in tables, That's the place to go for you. Another resource is from the Liverpool COVID-19 drug interactions database. I use this a lot. It's an online tool, terrific resource from University of Liverpool. And I'm going to show you in a minute how to use it. You just enter the drug you're using for COVID, the other drugs the person is taking, and it will tell you if there's a drug-drug interaction. Then lastly, I want to really point out these FDA website resources at the bottom. They have a wonderful fact sheet. It's kind of long. It's the label for the drug Paxlovid, but has all the detail you'd ever you'd ever want to know about the drug that's known. And then lastly, something that I've used, which is the Paxlovid patient eligibility screening checklist. This is a really lovely thing that FDA has put together. It's a one-pager. You can print it out, and it's a checklist to see if this is a person for whom Paxlovid is appropriate and indicated. Next slide, please. So let's look at this Liverpool database for a minute. This is what it looks like if you log on to the database. And over here on the left is a column for COVID drugs. In the center is a column for co-medications. And on the right is the outcome of the drug interactions. And what you do, if you go to the next slide, please, is you can start typing in the name of the drug that you intend to be using for COVID. In this case, it's nirmatrelvir with ritonavir. So I started with NIR and it brought it right up. And then I was worried about atorvastatin, a drug used for high cholesterol. So I typed in ATOR, brought up atorvastatin. And then you can see on the right that it will highlight, yes, there's a potential interaction. And you can click to go down and see what the interaction is and whether it's something that's concerning enough that you may need to adjust the dose of the atorvastatin. This database covers hundreds and hundreds of drugs. And importantly, if you note in red, if the drug's not listed and it can't be automatically assumed it's safe to co-administer. So they're making a really strong effort to get all the medicines in there, but I have not come across, and I've not heard of someone coming across a situation where a drug they're interested in is not in this database. Next slide, please. Last thing I want to talk about to keep this moving along is this phenomenon of COVID-19 rebound that people often think a lot about as being after Paxlovid treatment, because that's where we first heard about it. We were hearing of these stories of people who took Paxlovid for COVID, felt better, and then a few days later, they felt sick again. And some people who were monitoring their infection using the at-home antigen test noticed that their antigen test would go from positive when they were diagnosed to negative at the end of Paxlovid treatment. And then all of a sudden, when they felt ill again, that test became positive again. What was going on? Well, the manufacturer in the large clinical trial that looked at whether Paxlovid was a useful drug observed the same thing. In fact, they found there were either a small number of participants who tested positive after having tested negative in the course of the study, or some who at the end of the study, despite having completed their assigned treatment arm, the either placebo or the drug, had more virus detectable in their nasal swabs. And that was a little counterintuitive. Now, this wasn't a lot of people. It was maybe 10% of folks, 15, 20% of folks. It wasn't a lot of people. And what I really want to bring your attention to is this finding was seen in both people who got Paxlovid and the placebo, who got no real treatment. So we don't really know if this is something attributable to Paxlovid per se, or rather it may be part of the natural history of Omicron infection, which is this highly infectious now variant that's running around. Bottom line here, though, is even in people who had rebound, thankfully, there was no evidence of increased risk or need for hospitalization, no deaths. And also, there was no evidence that the rebound was a result of the virus developing resistance to the drug. So we know it still works. I would strongly encourage people for whom this drug is indicated to take it. Next slide, please. But what do you do if you experience rebound? Well, first of all, there's no evidence that you need to give people more treatment. The general anecdote that we hear, because unfortunately we haven't got good data yet, it's a relatively new phenomenon, but the frequent story we're hearing is that the rebound is not as severe as the first go round. Of course, there'll be exceptions to every rule, and that people do tend to get better on their own. What's probably going on, I think a good hypothesis, one that I find very appealing, is that it's just taking some people's immune system extra time to bring that virus under control, whether they have the help of the drug or they don't get it. What's important about rebound is this, that when it occurs, there is evidence that first, the amount of virus that a person is putting out from their body from the infection can be at a level high enough to infect another person. And there have been some infections that we believe occurred from a person who was in the rebound phase that they may have transmitted to someone else. As a result, for persons who experience rebound, CDC recommends that you isolate again for a 5-day period and then follow the same other steps we recommend for anyone who's diagnosed with COVID, including possibly ending isolation at 5 days if you are feeling better and had no fever in 24 hours, and wearing a mask for 10 days full after that. So that's what I wanted to share with you all today. I hope we have time to discuss it. And let me turn it back over to Dr. Waddell.
That's fantastic. That's fantastic. Thank you so much, Dr. Brooks. And we will have time for questions, and we definitely are getting some, so we will definitely get to those. But now we're going to hear from Dr. Cameron Webb, who's the Senior Policy Advisor for Equity COVID-19 Response Team with the White House. Dr. Webb will provide an overview on the Test to Treat initiative. Dr. Webb, we're so glad to have you back with us, and we're going to turn it over to you.
Perfect. Well, thanks so much. And it's great to be with you all this afternoon. Wanted to just talk to you briefly about one of our approaches to make sure we're getting drugs like Paxlovid to more people. As we know, this is a critical part of our plan, our approach to keeping more people safe through this pandemic. And so we know it reduces the likelihood of hospitalization and death. And so it's so important for us to get this to as many communities as possible. But what you have to keep in mind is that there are about 6 steps that you need to take from having a COVID infection to actually getting this treatment. You have to know that your symptoms are COVID-19. You have to get a test. You have to get that test result. You have to see a clinical provider. You need to get them to prescribe you Paxlovid. You need to pick up that prescription. That's a lot to do. And as you heard from Dr. Brooks, you have to do that in 5 days or less. And so what we knew from the beginning was that this was going to be an operational challenge, and it's going to coming with it, there are going to be some barriers to access. And that's where the Test to Treat initiative was born. It started in March of this year. And what we wanted to do is co-locate all 6 of those steps so that somebody who has COVID-19 symptoms can go to a location, get a test result, see a clinical provider, get a prescription, and leave with that prescription in hand. And all of those things being co-located can compress that timeline and make it more effective for them to get this treatment in a timely fashion. That's what we've been aiming to do. And the Test to Treat initiative has been ongoing, and it's working. We know that in the places where we have these Test to Treat sites, more people are able to get ready access to these treatments. But again, one of the challenges is that not every location where we have these treatments is a Test to Treat location. And so we know that we have about 40,000 sites all over the country that are dispensing Paxlovid at this point in time, but it's just a small fraction of them that are actual Test to Treat locations. And so one thing that we always want to encourage folks to do is know where they can find these spaces. If you go to covid.gov, you can go to that website and you can find where you can get these treatments. It's an important website, and all of your engagement, all of your activity with patients, with community members, with other community leaders, make sure that you're pointing people toward that website, because it's meant to be kind of a one-stop shop for a lot of these COVID-19 related resources that are available to you. And I'll talk more about that in a second. Now, when you go to covid.gov, you can enter your zip code. It'll allow you to zero in on where Paxlovid dispensing locations near you are. And that is a really important thing. Now, before I move on and talk about kind of the critical things that I hope you'll be communicating to folks as you move forward, I want to talk a little bit about what we're seeing. And you heard in my title, equity is a central focus, not just of my role, but really of the administration's response. We know that there's no success in this pandemic without focusing on equity. We know that some communities have been harder hit, have faced higher risk throughout, and we need to affirmatively work to support those communities with resources and tools. Well, here with Paxlovid in particular, even though we designed the dispenser, or the distribution rather, of Paxlovid so that it would be equitable, we got it out to so many different sites. I mentioned 40,000 sites that have Paxlovid. And if you think about it, about half of those sites are in the highest socially vulnerable communities by zip code. So we're getting it into the places that have been the hardest hit and highest risk in terms of location. But there's still a challenge in terms of getting it prescribed at higher levels in those communities. And we do have some bottlenecks. There was an MMWR report that came out just about a week and a half ago now. And that report did show that even though we have lots of sites of Paxlovid, the actual dispensing is lower in those high risks, so those higher social vulnerability index zip codes, than it is in places that have lower social vulnerability. This tracks with kind of our overall trends with access to care, but our job is to make sure we overcome some of those longstanding structural and systemic barriers. And so to do that, we're trying to make sure that we're getting more and more people access to these treatments, more and more people access to prescribers who can get them those treatments. And so, community health centers are a key part of that. Community health centers are hubs, are places where people know and trust, and they want to go for their care. And so we've invited all of our FQHCs across the country to be Paxlovid dispensing sites. And because of that, because they're also doing testing, because they're also, they have clinical assessment capabilities, they can ostensibly become test to treat sites, which is really important. And so we want to see more of that, and happy to assist in any way in helping our community health centers around the country be test to treat sites. But there's more that we want to and that we can be doing. We want to leverage the power of telehealth so more people can connect. We've seen in some states that's been a really powerful way to get more Paxlovid out to folks. And we're going to continue working with communities so that every site becomes, really optimized for its ability to give Paxlovid out into the community. I'm going to close by just saying that, yes, we're talking about treatments here and they're critical. And much like last year, when we talked a lot about vaccines and they have been so critical, it's important for people to realize that we're in a moment where preparedness is the key for navigating this pandemic. For a lot of folks, the experience is very different in their community from place to place. So there's no one size fits all, experience with COVID-19 right now. But what I tell people is there are 4 things that should be in your toolkit, a checklist of 4 things that everybody across the country should be doing or making sure they're tending to at all times. Those 4 things are these. First, you need to make sure you have a high quality mask or several high quality masks in your home. That's N95s, KN95 masks. We know those are essential to stopping the spread of the virus, particularly when your COVID community levels are higher. And so you don't want to be running around looking for a mask at the last minute because your community is suddenly seeing more transmission. You want to make sure you have those in your house, just like you make sure you have an umbrella by your door, just in case it's raining outside. That's a really important piece. So make sure you've got masks and you're sharing that with folks. The second thing is make sure you have tests. There's a lot of at-home tests that are available. You can go to covid.gov. You can order tests through there. You can get 16 shipped directly to homes. And so making sure everybody knows that. And we have tens of millions of households that have requested and received these tests delivered directly to them by the federal government. We need more folks to take advantage of that. We've sent out 500 million tests through that mechanism, but we want to send more. So make sure you take advantage of that. So masks and tests. The third thing are the vaccines. Have your highest level of vaccination coverage. We know that people needed to have their primary series, and we saw equitable rates of vaccines with primary series, but we have to do the same with boosters. We have to do the same with adolescent and pediatric vaccinations. And yes, now little peds vax for the under 5-year-olds. We need to make sure we're getting as many folks their highest level of coverage possible. That is a critical part of making sure you're navigating this pandemic. And the last one, going back to Paxlovid, going back to these oral antivirals, is don't wait until you have a COVID positive diagnosis to know whether or not you are somebody who would need these medicines. In your routine conversations and as you're talking in your communities, in routine conversations with healthcare providers, you should know if you've got the kind of medical conditions that would benefit from having this treatment on the front end. And you should have a plan for who you would call if you became COVID positive, where you would go in order to get these treatments. If you do that on the front end, it can make it a lot faster when you know that you have a small window of time to get these medications. So masks, tests, vaccines and treatments, that's your checklist. That's what we want to make sure that all communities know about. That's the preparedness plan that becomes so important. So thanks for giving me some time this afternoon to share with you. And thanks for all the work that you're doing. I'll pass it back to you.
Great. Thank you so much, Dr. Webb. We really appreciate you sharing that important information. And let me just reiterate, covid.gov. Lots of information there, a real resource for all of you on the call. So Dr. Webb, we know that you're not able to stay with us the entire time. So wanted to share with you that we've gotten some questions regarding insurance status. And so can you speak to those that if they're uninsured or they don't have a provider, what's their mechanism at this point in time regarding test to treat or other access to these important services and resources?
Yeah, so a couple of different things there. So the first thing to know is that these medications are paid for by the federal government. So we paid for 20 million courses of Paxlovid. That's what we've been distributing. So the medication itself, there's no cost for individuals to receive the medication. The second thing is we know that a large proportion of folks don't have a usual source of care. So even though we put Paxlovid in pharmacies and community health centers and other healthcare spaces across the country, we know that you still have to find somebody to prescribe it. And that's where the test to treat program is so important. If you don't have a usual source of care, don't have somebody who's your provider, you can search on covid.gov for a test to treat location, and that can connect you with the prescriber specifically to get you access to Paxlovid. So that's the reason, that's the design behind that. We're always trying to expand the number of sites that are test to treat sites, but that's one of the big mechanisms that we have. And I recognize some people, and you'll see this in your community, some folks are going to urgent care facilities to get access to prescriptions. They're going to emergency departments. We want to minimize that as much as possible, not because they're not important places for care, but because they can be costly for folks to navigate. And so we want to make sure we're not telling folks, oh, go to the emergency department to get your Paxlovid. Point them to covid.gov and let them know that it's really an important way for them to search and find test to treat locations near them so you can get access to those. Depending on your state and your community, there may be other options. You know, a lot of folks are aware, New York City, there's a number you can call, and then you call that number and you can get Paxlovid delivered directly to you. There are some innovative programs in Massachusetts and Minnesota. So places around the country are trying different approaches to make this widely available. So I think starting with covid.gov, seeing what the sites available near you are, and seeing what your state or locality is doing, I think that's really, really the key. But I think we had to know at the very beginning, or we were very aware that not everybody has that usual source of care. Up to 1 in 4 people don't. And so we wanted to design a strategy to reach them too.
That's great. I'm going to throw a couple of quickies, quick questions at you before you have to leave. I guess number one is, we may have folks on this call that are not sites and perhaps may be interested in becoming a test to treat site. Is there a place that they should follow up on around that? And then the second is, we had some questions from folks that may have said, well, you know, I did a home test. And so, you know, can I take that home test in, or what do I need to do?
Yeah, so for test to treat sites, to answer your second question, you can take that home test in. And that's important because if you have that home test, you can take that in, you can get access to the treatment. You know, our goal wasn't to create an additional barrier. You don't have to get a laboratory-based test to confirm that it's COVID-19. So that's one important thing, that home test, you can bring that with you, and that can be kind of your way of getting access. I think the second thing to keep in mind for places that do want to become test to treat locations, it depends on what kind of site that you are. So, you know, through HRSA, I know there's been a lot of outreach. So if you're a federally qualified health center, community health center, you can reach out, you know, through HRSA specifically, and they can help plug you in with that program. And I'm sure we can get some resources out to folks who participate on this call afterwards, so they can follow up there. The other, you know, a lot of those sites are, you know, pharmacy-based retail clinics. And so those are spaces that are a lot of our test to treat sites. A large part of that footprint is CVS and minute clinic type locations. And so we want to leverage all of those that we can. And we've specifically asked them in particular, turn on the ones in the high SVI or the communities with greater social vulnerability, because those are the places where it can really do the most good. That's where you're going to see even more of the folks who don't have a usual source of care who can really benefit from it. And so you know, those are important dynamics there, but certainly follow up with us from this call, and we can help point you in the right direction depending on the type of location you are.
Fantastic. Thank you so much, Dr. Webb. We know how busy you are and certainly appreciate your time and your expertise with us today. And please stay with us as long as you can. So now we're going to hear from Dr. Julia Skapik, who is the Chief Medical Information Officer with the National Association of Community Health Centers, also known as NAC. Dr. Skapik will discuss some of the biggest barriers the National Association of Community Health Centers are seeing across the country and recommendations from their experience. We want to hear, what are those challenges, and then what are some of those solutions, so that all of you can learn from each other on the call today. So Dr. Skapik, I'll turn it to you.
Thank you so much for inviting NAC and community health centers to be such an important part of the pandemic response. I want to start by thanking everyone who's working on the front lines at FQHCs and lookalikes to combat the pandemic. We know that you're tired, and we really appreciate all you've done to protect our nation. I think we've heard a lot about FQHCs already, so I don't need to probably belabor the point, but FQHCs make up the nation's outpatient healthcare safety net, and NAC has over 1,400 health center members with over 13,000 sites in the United States and its territories that do medical care, but also cover essential services like food, housing, dental, pharmacy, behavioral health, all key components to keeping people well. You know, in my opinion, and I see patients at a federally qualified health center in Northern Virginia as a primary care provider, The biggest barrier is still people just knowing about the availability of treatment and how and when to access it. We'll frequently see people who call in several days after a diagnosis, and it's really just too late for them to get access to the antivirals. Furthermore, many patients really aren't sure what the criteria are for whether or not they should be treated. And this is actually something I've started talking about with patients, especially who are in older age ranges, to let them know if one of their friends or family members test positive, that they should try to access treatment through our clinic or through a test to treat site. Oftentimes, there are a number of barriers. One, the patient sort of waits to test. So maybe they don't get a test or test positive until they've already been ill for several days. But 2, they wait to call. 3, they don't get right through to someone who knows, oh, we need to fast track everyone who might be test to treat candidates directly to a provider that day so that they can be properly evaluated. And I would love to see, all of us really do everything we can to use all of the social media, community organization resources at our disposal to really make this part of the daily conversation around COVID. As we see BA.5 emerging in other places and it having a higher burden of hospitalization, this is our big opportunity, I think, hopefully to use antivirals to keep more of our high-risk patients safe. We do see actually that discomfort or lack of confidence in the area of understanding the appropriate use of these antivirals with providers and care teams is actually a barrier on its own. So knowing that there are some complicated drug-drug interactions, not being totally confident as to who the highest risk patients are and whether or not the risk benefit will be to their advantage, has kept, I think, some people from utilizing Paxlovid. And I've even heard providers say things like, oh, I don't prescribe it. And I think that that's okay. We don't want to push people out of their comfort zone at all. I think the right approach, though, is making sure that everyone in an organization that provides test to treat or that treats COVID knows who the people are who are those confident and knowledgeable providers and how to immediately get access to them. I do see most of my patients at this point testing positive at home. Very few people are coming into our clinic to get tested in comparison to what we saw early in the pandemic, where basically every one of our sites had a tent in the parking lot and people were just streaming into that tent all day long getting tests. I think actually there's a benefit to keeping people out of the office in terms of protecting our healthcare workers. And so I think it's really important to create this telemedicine-based approach to doing test to treat. And that probably starts with creating a health center or health organization test to treat team. That team should be multidisciplinary. We certainly want to work with the pharmacist so that you have access to someone who can help answer questions about drug-drug interactions. You want to work with the front desk and the medical assistants who are more likely to run into a patient who might have questions about test to treat, but also might call in and say, well, I think I have COVID, and to make sure that that person doesn't get an appointment 3 days from now when it's too late for them to get tested. We also want to make sure that everyone who's doing counseling both can have a successful conversation about risks and benefits and about what side effects are. I remember the first patient I treated, I called her 3 days later for a telemedicine visit to see how she was doing. And she said, Dr. Skapik, I had every single one of the side effects that you told me this medicine would have. So being realistic also to patients will prevent us from having a rebound effect of people feeling really sick and stopping the medication early or telling their friends, I took it and it was terrible, don't take it, which of course is not helpful for someone who's truly high risk. So having that team work on what is the best approach for us to deliver this care, and that may be, or optimally might be, having a couple telemedicine visits at the end of every single day so that anyone who tests positive can immediately be slotted into those and treated as soon as possible. And then doing an educational campaign within the staff, but also in the clinic to our patients. So, we'd actually had a really successful campaign recently where we put a sign basically on every wall of the clinic about the patient portal in multiple languages and how to use it. And our patient portal use went way up. So why not have a sign in every part of the clinic? If you test positive for COVID, call us to see if you should be a candidate. Here are some categories of risk where you should call, age, comorbidities, et cetera. And then I think that we can take this a step farther, right? We can take it at the national level, and NAC, by the way, is working on creating a toolkit for sites that are doing test to treat to help them to make sure they've checked all the boxes and thought about all the potential barriers as they're going through this work. We're hoping that we see CDC and others continue some of these national campaign efforts. We had actually a really successful COVID education campaign based in Southern California, where different health centers that treated different culturally specific communities had their staff do a little challenge where instead of just translating English-facing materials from somewhere like the health department into another language, they actually recontextualized the message in that cultural specific language and context. So, the Spanish translation, it rhymed in Spanish. It wasn't just a word for word translation in English. So thinking about who are those communities that you're trying to reach and how do you provide the message about test to treat that, regardless of your vaccination status, this medication can benefit you, especially if you're not vaccinated, this medication can benefit you. It is easy to access. Some of our patients have become aware that the HRSA uninsured program has ended, but we do want them to know that they can still access antiviral therapy. And working with community organizations, which health centers do extremely well to get that message out, I think can be extremely powerful in, telling community members, even who aren't patients of our organization, you can come to us and you can get access to this. And, this is something that will benefit you and the community, because identifying COVID and stopping the spread helps everyone. And keeping people out of the hospital also helps our communities. So, just taking all of those pieces together and ensuring that there's sort of confidence in the approach, our patients can see that from us. If we say, we know what to do, we know how to help you, this is your choice, of course, but here's why we think you'll benefit. Here's your option. Please work with us and take it and tell your friends. We think that's how we're going to take test to treat from a little bit of a pilot project to a real national opportunity to use this new technology to fight the pandemic.
Dr. Skapik, thank you so much. I mean, those was just such a nice summary of so many of just the real barriers that everyone's facing and what are some of the solutions. And just a reminder of some of the simple things like the signage, right? And the acknowledgement that, yeah, there are some providers that may not be comfortable. So how training and that peer-to-peer education is also important. So thank you so much for those reflections. So now we're going to turn it to Dr. James Coleman, who, as I mentioned earlier, is the CEO of the CA Carmichael Health Center, a federally qualified community health center in rural Mississippi. And so I'm sure there are many on the call that can relate to the communities that Dr. Coleman and his team are serving. And so Dr. Coleman, we want to just hear from you about what are some of those real challenges, and more specifically, you've been innovative and creative and been some of the first in the nation to do some things around overcoming access barriers to COVID testing and treatment. So tell us about what you all are doing there and what tips and tools you might be able to share with your colleagues and others on the ground across the country. And let's make sure you unmute, Dr. Coleman.
There you go. Thank you very much, Dr. Waddell and other colleagues for this awesome opportunity. And I'll just jump right into what we're here to discuss. Some of the barriers that we have seen and overcame, I will put into certain categories. And the first category is vaccine and treatment hesitancy. Within that space and within that treatment space, one of the things that we need to understand, one of my favorite book says, "In all thy getting, get an understanding." And there's also an adage that says, "Knowledge is power." Well, one of the things that we've done is people needed to know what, one, the vaccine is, two, what COVID is, and three, what treatment options there are and what these options meant. So in that space, we made sure that we talked about the importance of testing, the importance of treatment, as well as what is the treatment, what are the side effects, what are the fears and the things that people needed to be concerned about. And in this vaccine hesitancy, educating the community, we also used health fairs, we used outreach opportunities to make sure that when we went into the community or the community came to us, we had easy to read information that is at a certain readability level so that persons could understand and get a knowledge of what was going on. Another space that we looked at was access. Mississippi is very sparse. We have the Delta region. A lot of people have transportation barriers. But one of the blessings that we've had was the fact that we have what's called a mobile unit. The mobile unit was able to go into the community, and those communities that saw the mobile unit, it was like an effect where mayors and congressmen and other types of pastors or churches or city reps would even call us to actually come set up testing events, treatment events within their community so that we had a space so that persons could, easily get to where we were, and we actually took the mobile unit to them. Another issue that Dr. Stafford talked about was staffing. We also had providers that were very concerned about testing and treatment and making sure that they were safe. So what we did create that. It's not a test to treat team yet, but we did create a COVID-19 team. We used the same staff members to actually do the testing, the treatment, had front desk, we had behavioral health, we had, different entities represented within that team that actually went out to all the events with the mobile unit. And what we incentivized our staff with, we made sure that our salaries were competitive and made sure that we did certain things with these salaries so that, persons understood that we were there, that our staff were dedicated, and we were here for those particular reasons. Another area was marketing. We found marketing very effective. We were one of the first health centers to actually create a commercial. And in this commercial, we used a nurse practitioner who is the lead of the COVID health team to actually talk about vaccines, talk about monoclonal immunotherapy, talk about Paxlovid and what it does and what it is. So we actually had someone that they would see at the site, but also trusted with the type of medical information that was needed to take into the community. So that commercial really springboarded us into that scope where we actually had persons that were calling, asking. We even had people asking, how did you get into that spot in terms of those sports events? And we found that our testing and treatment options actually increased because of our commercials. And last but not least, one of the things that we also did, now that Paxlovid is available, we actually can take this onto the mobile unit and actually have it available in the community once we see that persons are testing positive with the COVID virus. So that would cut down on the access to care barrier, and it would also get the medications into the community. We're already there doing the testing and treatment of the community, but we actually can get it out there. And one of the highlights of what we did do as the first in the nation is this. We have what's called a modular unit, and that modular unit is on our site. And in that modular unit, all of the testing, all of the treatment is actually done at the modular unit and not inside the building of the health center. That modular unit actually has a negative pressure room where we have space where persons can get treated and not have to worry about becoming infected. And with this modular unit, there was an organization out of New York that actually designed and built it for us, but it's actually on the site, and persons who, cannot necessarily get to the modular unit, that's why we would use the Paxlovid to get to the community. But once people are here on site doing the testing and see that they're positive for COVID, then we get them into the modular unit to make sure that we start that treatment immediately. This word got out because there were some organizations in the area that was doing monoclonal therapy, but certain populations of persons did not know about it. So we made sure that we made GA Carmichael available so that anybody could come in. We also found that there was some misinformation given that persons did not understand that testing and treatment options were free of charge. Certain places were charging, and persons may not have all the resources that they needed. So we made sure that within these commercials, within the marketing materials, within the outreach events, we made sure that we express and, let people know that these were treatment options that were free of charge. This was one of the things that community health centers were good about doing, is providing that care, that treatment for those persons within those communities. So we're very proud of the fact that we have had these modular units. We've had, the mobile unit going out in the community. Now we're blessed with 2 mobile units. So we actually have 2 teams that actually, when persons call and meet us in different parts of the community, we can actually take 2 teams with 2 mobile units within our community and make sure that persons are getting the care and the treatment that they so rightfully deserve. And last point I would like to make, when we see that certain communities are calling, the beauty shops, the barber shops, fraternities, and sororities, when they're having their different events, it's very important for us to understand that collaboration is important. Partnership development is important. We can't do it all, but we may have resources that another entity does not have. They may have resources that we don't have, but when we collectively come together as one entity, showing the strength in our community as one unit, that's when we can affect change. And I think it's very important for people to understand that none of us need to own or have credit for anything. It's about serving our people, making sure that we're sharing our resources, and being there to lift each other up, because this pandemic is tiresome to everyone. There's fatigue everywhere. Yes. But when we help one another and we partner and we share our resources, we then have the strength that we need to make it yet another day. So I just want to, again, thank you. I'm here for the questions. GA Carmichael website is out there, and I'm just so excited about how we're making changes as it relates to addressing this COVID pandemic.
Great. Thank you so much, Dr. Coleman, for sharing, all of those tips. Clearly, you've had a multi-pronged strategy: awareness, access, staffing, marketing, your modular unit, and most importantly, the power of collaboration and partnership and leveraging everyone's assets and strengths. Look, we've got some polls we want to get to all of you all and a few questions in the 10 minutes that we've got remaining. So for our presenters, I'm going to share some questions with you, but I ask first that you be brief. So first of all, again, thank you, Dr. Coleman. Now, before we get to those questions and answers, we mentioned that we've got some polling. We want to get your input. We want to hear your recommendations on what federal, state, and local agencies can do to help improve equitable access to treatments and programs discussed today. Your feedback and your insights are really important. So we want to share these questions that are up here on the screen and ask that you type your answers in, and we'll collate those and make sure we share that information. So while we move on to our questions and answers, again, please take a time and share your feedback. So we've got some questions, Dr. Brooks, around some medication questions. And so members of the LGBTQ community are hearing conflicting messaging on medication interactions and COVID-19 antivirals, or hormone therapies and PrEP contraindications for Paxlovid. Can you address some of these types of questions, please?
Yeah, absolutely. I'm sorry there's conflicting information. Generally, those are not contraindicated with Paxlovid. But what I would recommend you do is, since there are different medicines, both in terms of the hormonal therapies that are available, as well as different forms of PrEP, is go to that Liverpool website and enter nirmatrelvir ritonavir, NIR, just type in NIR, that will bring in the Paxlovid, then type in the other field the medication you're concerned about, and it will show you if there are drug-drug interactions.
Thank you. Dr. Brooks, another question for you. Are there any COVID-19 antivirals in research or will be manufactured for children under 12 years of age?
Yeah, that's an excellent question. In fact, some of them are under 12. Sorry, I was about to say some of them do have a indication for pediatrics, but not under the age of 12, down to 40 kilograms, I believe, right now. I'd have to go back and check. I think one of them may be for younger kids, but the point here I want to make is that first, there are other drugs being are under investigation. There will be more drugs coming along, and a number of manufacturers are exploring by doing studies to show that these are safe and effective in children who are under the age of 12. I will get back to you in a moment, Dr. Waddell, with one of the medications that I'm almost certain is available to kids down to age 1, but I need to check to be certain.
All right. Perfect. Thank you. So look, this question's for Dr. Coleman and Dr. Skapik. One of the biggest barriers some community-based organizations are facing right now, the lack of resources to run COVID-19 initiatives, especially if they don't have buy-in from key individuals in positions in leadership. Do either of you have you experienced this? And if so, how have you overcome this barrier?
Dr. Skapik or I? One of the things that we did, we met with community leaders in small groups to educate them first, to give them an understanding of what was going on, why it's important. We're in an interesting state where we have individuals that truly need to understand what it is. So those small group meetings were very important. We also have resources from the state health department, as well as the federal government, that we will tell people, we have the resources, we have the tests, we have the pills, we just need you as a partner to get the information out. But once we get you to understand what's going on, we want you to help us to help your community to understand what's going on. So the resources sometimes is not really the issue. The issue really is about everybody understanding their role in the partnership.
Yeah, I'll just add to that. You know, the test to treat team should include people who are on the operations and administration side. Test to treat is really just regular healthcare. So if you're in a regular healthcare organization, you can think of this as an extension of services that you provide. I love Dr. Coleman's comments about working with your public health department and community organizations, because they will see the value in this. And you can always reach out to HRSA and to NAC if you're struggling with how to make this operationally viable. I think you can start small, and if the demand is there, you can scale up, but you'll get reimbursed for doing this kind of care the way you get reimbursed for, you know, a regular sick visit for a cold.
Great, thank you. So I think this could be for Dr. Brooks or Dr. Skapik, but questions again around just high level. How will we know who's eligible for Paxlovid? So I think maybe re-emphasizing that point. And then should we refer each person who has tested positive, or is it only those individuals with otherwise who have chronic illnesses or high-risk patients? So looks like it needs a little bit of clarification around the eligibility for
that's something we thought a lot about, and I put something in the chat in response to one of the questions. It's in the Q&A that goes into more detail. I just want to remind folks first, there is a link that goes to the CDC website that lists the high-risk conditions. Sometimes people feel that they don't belong to that list of high-risk conditions, but I want to remind you that they include some of the most common things that people have, not only asthma, but hypertension and obesity, which unfortunately many of us are experiencing in our country. So there may be people who you think may not be eligible because they don't have some horrible comorbid condition, but in fact are eligible. So check that out, first of all. Secondly, these drugs are intended to be used to keep people out of the hospital by treating them as an outpatient. When the manufacturers, in the one I know of best is Paxlovid, when they looked in their studies at people who did not have one of these comorbid conditions and then was given Paxlovid, it didn't make any difference in their risk for hospitalization versus people who got a placebo. We're very careful about giving people medication because even though it is often beneficial, there can be side effects. And Paxlovid in particular has a lot of things going on. So we want to make sure that people who need it get it, and we're not giving it to people for whom it may not be useful and could introduce harmful side effects.
Yeah, and I think as you create communication materials designed for patients, you also want to have very quick and easy references for your care team members. So, a list of those most common conditions in the back of the clinic, maybe in the workroom, or even in the space where you do your tests, run your tests, can be helpful in reminding you, oh, these are the high-risk conditions. Paxlovid is not indicated for someone who has not tested positive for COVID, but it's also not indicated for someone who's young and healthy and at low risk. So there are side effects. When you have patients who'll ask for it because they test positive, you want to point out to them that, if there's not a benefit, then any risk due to the drug is all negative, and that's often helpful.
And Dr. Waddell, I want to answer the question you asked previously. Joan Duvey very kindly found it just about as fast as I did, though she's quick. She was much better than me. And it's remdesivir is the drug. That's the one that's given as an infusion 3 days apart, that can be given to children down to 3 kilograms, I believe.
Great. Thank you so much. Well, our time is upon us already. Just so much great information shared today. We heard from Dr. Webb, and just to recap, the importance of his 4 key points around having high quality masks in your home, having tests available, making sure that we're getting our vaccinations at the highest level of coverage, making sure you're fully up to date, and don't wait until you've got an issue to find out where you can access your medications. Know that in advance. We heard about a number of what are some of the barriers that folks are facing out there, and what are some of the solutions. The importance of using social media and making this part of the daily conversation around COVID. Dr. Skapik shared that tip with us. Be realistic, recognize that the providers are on a fast learning curve too. They're there to help all of us. So let's continue to ask questions. Dr. Coleman, shared, the importance of a multi-pronged strategy, the key points around partnerships, and then a number of tools were shared also by Dr. Brooks. So this webinar has been recorded. It will be available to all of you afterwards. I encourage you to take a look at it again, share it with those that were not able to be on the call today, because these treatments can save lives, and we want to make sure that you have all the information that you need as community-based organizations, as health departments, as partners, to help us all get through this together. So you've got the post-webinar survey on your screen here. Again, we thank all of you for joining us today, for asking your questions, sharing your perspectives, and we look forward to having you join us at our next webinar in the next few months, I guess. So with that, I think we will call it a wrap for today. Again, thank you to all of our presenters and to all of you. Have a great day.